welcome. By now, you should have all received those W-2 and 1099 forms that inform you and the IRS just how much or little money you earned last year. This will be an especially important number because soon it will be time to figure out if Obamacare, the Affordable Health Care Act, is affordable for you. The answer will very much depend on how the program just being born is delivered in each state. In a moment, we'll examine this in detail for New York, especially the redesign of New York's healthcare system. Also on tonight's program, breast cancer. A recent study suggests many women would live just as long, maybe longer, choosing the less radical surgery that conserves the breast. We'll ask if that's true, and a larger question about medicine: how much are treatments determined by cultural norms rather than science? And also today, breaking open the museums of the world by putting them online. Whose Mona Lisa is it anyway? First, Obamacare. It's almost here in full force. Right now, frantic behind-the-scenes preparations are underway, and in less than 8 months, roughly 2.5 million New Yorkers are expected to begin to shop for health care coverage set to begin next January. But how will that work exactly? Yes, Obamacare is legal, thank you, Supreme Court, but it is still controversial as it's being ramped up. Here to tell us what to expect this fall, Barbara Glickstein, co-director of Hunter College's Center for Health, Media, and Policy. She also hosts Health Styles on WBAI Radio. And with us as well, Elisabeth Ryder-Benjamin, Vice President of Health Initiatives at the Community Service Society, and she co-founded the Healthcare for All New York campaign, a large coalition of groups organizing for Obamacare. Welcome to both of you. Thank you for coming in. Elisabeth, was that 2.5 million figure that I cited about accurate? Is that about how many New Yorkers will now start getting different kinds of health care coverage under Obamacare?
I think that's a little high. There's 2.7 million uninsured people. They expect roughly as many as 1 million to go through the state individual exchange and another 450,000 to go through the small business or shop exchange. These exchanges are marketplaces where people can make apples-to-apples comparisons and shop for coverage, and we can talk more about them. But the other thing that happens is you're pooling a lot of people's health insurance risks together so that prices should drop. And so that's sort of the guts of the Obamacare.
And as a public health nurse, are you confident that that will actually happen? Will the Affordable Care Act make private health insurance more affordable in New York?
Well, it definitely will. The question is, making it more affordable, will it still be affordable for the New Yorkers who need to have coverage? So I think what we can help our communities understand is maybe referring to the exchange as a marketplace, which I understand Secretary Sebelius is suggesting exchange is kind of policy wonky, and let's help people understand that it's a marketplace and that maybe it's really too big a mall, and I hate malls, so shopping may not be easy, but we're going to try through today's segment and I think throughout the next few months to help people really understand what it is that's being offered so that A, if they can afford it, and B, they understand what policy matches their individual and family needs, and then they purchase it and then are taught how to use it, we'll be in really good shape. So it's not a perfect system, but I think what we want to do is not politicize yet again the Affordable Care Act in this segment of the rollout so that communities understand how to use it, which is, I think, really a benefit to all of us.
One thing about these marketplaces is really important. These exchanges right now, there's 50, if you went out to buy health insurance as a small employer, for example, you would have a choice of 15,000 different insurance policies. That's nonsense. It becomes gobbledygook.
That's a good thing, isn't it?
No.
Because it means they're competing with each other and competition brings down price
so it means you have to
quality.
It means you have to use a broker, which is fine, but brokers are on commission to insurance companies. So the idea is these exchanges, what New York has made one very important decision. Instead of saying, okay, all 15,000 policies will be shown on our marketplace, they issued what's called a plan invitation last week saying, well, no. We're going to say each plan is allowed to offer no more than 4 products at each of the different, they're called precious metal levels, so a very inexpensive plan to a middle price plan to an even better plan to a top tier plan. And so that should really radically reduce how much choice to make it sort of sensible But remember, there's still 10, 12 carriers in New York State that might be offering coverage. So
Right.
you have a lot of choices, and this marketplace is really a website, kind of like Orbitz, but more realistically like TurboTax. It's going to be a little
What does that mean? The difference between Orbitz and TurboTax?
So
for this
Orbitz is
what?
pretty easy. You know, you just pick the plane. You look at 3 different plane rides to your destination. You see which one's the cheapest or on the dates you want it. You fill in your dates and how many passengers and your name and address and credit card number. You're done. With the Affordable Care Act and this online marketplace, it's a little more complicated. You have to list every single person in your household. You have to list their social security number. The good news is you don't have to list their income, because once you issue their social security number, there'll be this behind the scenes instant matching. So they'll say, hey, is this the income of this person? Yes or no?
Because it'll coordinate with your last IRS return?
Correct.
Aha.
Correct. So, and then you'll say, oh, I'm expecting a bonus, or I'm getting a raise, or I just got a raise, and you can fix that.
Estimate how much your
So that makes
purchase
it a little more
price is gonna be.
TurboTaxy, because
Right.
you have to go
So-
through that for each member of your household, and then you have
Right.
to select a plan, and
Yes,
you have to
I get
compare
it.
the plans.
And can you get even more specific and give an example of what a household with X income might be charged for one kind of plan versus the better kind of plan?
Well, if this was not a glass of water or a mug of water and a crystal ball, I might be able to give you that exact answer, Brian. But I think the specifics of what and the range of what these plans will be is still in question. And what I understand is that they will be lower by 7 to 10% of what's available, or perhaps less.
No, it'll be 70% lower in the individual market. Prices will drop up to 70%.
70%.
Compared to what an individual
Right,
would
right
pay
now
today?
an individual pays $1,200 on the open market per month. That will go down to whatever, $300 or $400.
For the same plan.
For that same plan, but on top of that, if you're, for example, a family of 3 at 200% of poverty, which is around $37,000 a year, you will pay no more than $2,300 in premiums for the year. That's still a lot of money. There's still this problem about affordability, but there's these caps, but you have to opt into the silver level plan. The cheapest is bronze, so that's going to be the only pay.
The
Insurance
metals.
companies will only pay 60% of the cost. Silver, the insurance companies pay around 70% of the cost, but you can get all these extra cost-sharing protections if you're a lower income person. And then gold, they pay around 80%, and platinum is around 90% of your cost. So obviously, the very wealthy will probably go, or the very sick will probably go for a platinum product.
So, which is to say that these different metal levels aren't about
Thank you,
how
Romney
good
Care, by the way.
Romney Care in Massachusetts.
Yeah, it uses
where-
the
'cause he
precious metals because
really,
of the Olympics.
He pioneered it.
Yeah, it was his Olympic experience, so that's why it's all about.
Aha,
Yeah.
gold medal.
Yeah.
But they don't have a platinum medal at the Olympics. But does the platinum?
may be in
does
the
that mean
future.
the platinum plan gives you the most subsidy, or does it mean
No.
it has the broadest coverage?
The one, they peg the subsidy at the second lowest level. So, because they don't want us to consume health care, right? So the theory is if you only you encourage people to go to the second lowest level, you'll be encouraging less use.
Yes.
Because they blame the patients for overutilizing healthcare system. I don't agree with that particular analysis, but that's the theory.
So can you give us a very concrete example or two, either of you, of what's not in the lowest plan that is in some higher up plan? Because we've just been having this big national debate about things that the president and Congress mandated be in all the plans, like free contraception coverage.
Right. No, it's not how it works. It's going to be about cost sharing. So it's the precious metals are organized on how much out of pocket you have. They basically have to adopt an essential health benefits package.
Right.
Sorry, I didn't mean to interrupt.
No,
but
you have this down to the level that I
Which is-
really appreciate it because you're explaining it so beautifully.
in New York, it's the Oxford small group product. Plus, they added a couple of things else that had to be in there because under the Act, the Affordable Care Act, there's 10 sort of components of the essential health benefits. I don't want to get too detailed on here, but New York said we're going to peg that to an Oxford small group product. And so the benefits are pretty much stuck. What you can do, what deviates according to the precious metals is how much you're going to be stuck out of pocket. And number two,
Like
if
what
you
your
want
copay is and things like that.
exactly,
And
how much, and the
deductible.
coinsurance. I mean, how much
Yes.
and the deductible and how much your premium is going to be. And remember, you want that silver level tier because that's where you get the most protection and most affordability, like subsidies.
Right.
You'll get subsidies under that tier.
So, I mean, I just think about my own personal experience in moments like this when, through my employer and other times where I've had to, as a freelancer, purchase my own insurance, that as engaged as I am in healthcare and follow these issues, I spend hours and hours and hours trying to decide what it should be. And I think one of the things the state will have are people who are, like Elisabeth here, very versed in the plans, but also helping people to be matched with what it is they need. So we don't always know what's going to happen. Of course, that's life. But in terms of what your current needs are, whether you come and show up with a chronic disease and you have a family member who also has a child who has an illness that requires regular checkups, those kinds of variables will help you in that decision-making process, and hopefully in a kind, compassionate, and clear way, and culturally sensitive as well. I know that language, the availability of these programs being available in other languages is also being planned for people whose English is not their first language. But I think that for the population of people who have had no insurance, who are now entering into an opportunity to purchase insurance, there's a learning curve and an anxiety curve, to be quite frank, that I hope, in addition to those who are going to be involved directly, that healthcare providers will become more versed in this, so that if you're seeing someone and have an opportunity to say, you know, you're in a good situation come October to start looking at insurance, and then these, let's say, clinic visits or ER visits where you're using as your primary care would be reduced, and you can start getting a primary care access through this type of insurance.
But you don't think a lot of people just sort of still won't get it? I mean, it's complicated enough the way you guys are describing it. You guys really understand, so that people will still just go to the emergency rooms?
Yes, I do. I think that's going to take a while. We have a cultural shift. I actually called a good friend of mine who's a senior ER nurse at Cornell and said, what do you think? What are your concerns? And she said, one, people who are currently using the emergency room, because that's their access point, will continue doing so because they won't afford it. Two, those who maybe still might be able to afford it may get it and still think that's what they've been using their entire life, their family's life, a second, third generation of ER being their primary access point. And that's another place where that education effort will have to take place and guide people to better services, where waiting 12 hours when you have a flu to be told to take Robitussin and go home and rest is not the best use of your time or the emergency room department.
So the state's setting up 3 vehicles for doing this kind of helping people through it. One, at the emergency room, and most hospitals will be, and this is just hot off the presses and the federal rules, they're going to have certified application assisters. So there'll be people based at providers who can help people enroll. The state also will have a call-in center to support that website. So as you're doing an electronic enrollment or signing on, logging in and signing up and setting up your account, you'll have someone that can walk you through it on the phone if you're comfortable on the phone. That's the second mechanism. So certified application assisters, then the call-in center. And the third thing that really is most important for communities is they're setting up that's called a navigator program. And that's going to be resources, grants to community-based organizations, hopefully such as mine, but maybe not, you know, we all have to bid. But, you know, they can help walk people through it. And people, many people, when we look at people who are racial and linguistic minorities, low-income people, seniors, it's very hard for them to do things online often, and it's very intimidating. And so those folks will have this in-person assistance.
So is there also going to be public relations rollout of this?
Yes.
You know, should they use, probably not Donald Trump, maybe Derek Jeter,
That's
Jay-Z
who I've been voting for.
Beyonce.
He has nothing to do. He's got a broken ankle.
No, he's well. He's going to be ready for spring training.
No way.
Yes,
we
definitely.
want him out there for Obamacare.
But
Yeah, okay.
well,
so what,
I
in your fantasy life,
It was Derek Jeter. That's what I always think.
And this doesn't start really until next year's World Series, this year's World Series time, right? So
Right.
he's got a little time to get there yet.
Exactly.
But what would he say?
I mean, I think he would say, I've got mine, do you have yours? You know, get covered. This is important, you know, for you and for your families. And that's what the Red Sox did in Massachusetts. They have 90%, 8% coverage. So I think we really do want every sports team, whoever's the Derek Jeter on
Well,
every sports
we
team
can
out there
ask-
doing it. And the state is also, you know, seeking federal funding to support the retention of a fancy PR firm to sort of think through a real rollout PR strategy. And I think the state's being really smart about that.
And I think that organizations like Elisabeth's as well have their eyes and their ears in a lot of the community-based organizations to where the community goes. You know, I mean, I'm a regular user of our public library, and every day there are so many people using the computers there who don't have access at home.
Right.
So I can see some communities having a navigator or a person like that in their public library who can be that spokesperson without, of course, I'd love Derek Jeter also to be. Jay-Z could do it. We certainly know that those kinds of spots on both radio and television really help people get to that place where they can get more information.
And then what happens to people who are still so low income that
And undocumented people in New York State also are not going to be eligible for any of the Affordable Care Act, unfortunately.
who then decide that they still can't afford to buy these policies even at these subsidized rates?
Well, one concern is that some of the safety nets, like monies to our institutions that are covering people who come into the emergency room without insurance, are going to be hurting. I think there are some unanswered questions about those populations. I think the more we move towards community-based practice and our clinics that don't turn people away and have ways of accessing care will hopefully become stronger, and those people eventually, as we move forward, will have more access.
But if they don't buy and they file tax returns, there's going to be a penalty, and it'll get more and more each year that they don't buy, correct?
Correct.
It escalates.
So it's a problem. I mean, I think people in Massachusetts, they are seeing that people have chose to opt out.
I think the biggest problem is people who are actually eligible for public health insurance, like Medicaid. There's no mandate on them. You can't. The law doesn't require someone to sign up for Medicaid. So right now we have 1 million people eligible for Medicaid or public health insurance who are not enrolled. 260,000 kids who are eligible for CHIP but not enrolled, and those folks. We're hoping there's kind of a welcome mat effect with everybody talking about this mandate, but in fact, there's no requirement for someone on Medicaid to join Medicaid.
And so,
or someone Medicaid eligible to join.
Yes. So are employers going to now drop their employer plans because the federal government is now mandating that individuals in that position buy their plans individually, and so employers can say, hey, I don't have to do this anymore?
Well, they'll be in big trouble if they do. The penalties will be high, and I don't think...
Penalties for dropping existing employer plans?
Yes. And Elisabeth...
So for small businesses with less than 50 employees, there's no penalty at all. In fact, starting right now, you can have a 30% tax credit, which means the federal government reimburses you for 30% of you're covering your employees.
If you start to cover your employees.
No, already. If you were just happen to be doing it all along,
Right.
or if you start, either.
As a small business with under 50 employees.
Under 50 employees, and that escalates to 50% of the cost of offering coverage starting January 1st, 2014. So there's real carrots, no sticks, no requirement on small businesses to offer coverage. For employers that are 50 or larger, there are some penalties that are assessed, after a certain number of employees, and they can be pretty stiff, So there's a real stick there that for, larger employers. But at the end of the day, most of those employers are already offering coverage.
So when does this start? We're just about out of time. When are people actually going to need to go take action? Because those exchanges, those marketplaces are not active yet, right?
Nope, but they have until October to keep learning all about this. And I think one of the topics that maybe we can come back to at a later date is how are we then going to provide primary care for all of these new enrollees and look at the issues of obstacles to having other providers like nurse practitioners and physician associates be there to welcome these 1 million people in New York State and provide them with good care.
The doors open for the exchange on October 1st, 2013, so that's roughly in 6-7 months, and you need to start enrolling, and you have an enrollment period up to December 31st, 2013, so you need to get yourself enrolled.
Last thing, does it matter to New York what happens in the rest of the country? Because half the states, primarily those with Republican governors, are saying, no, we're not going to set up our healthcare exchanges.
That's so crazy.
Federal government, if you're insistent
they're giving
on
it to the federal government.
I
I think we're chipping away to universal health care, and I'm kind of happy to see this all, see where it goes.
So all those red states are deferring to the federal government instead of doing state flexibility and states' rights. It's very
interesting.
It's very counterintuitive.
Yeah. But I'm hopeful. I think we're actually maybe moving in a direction one day where all these exchanges will become one and people will have one access point for insurance and coverage.
That's another 100 year for a single payer.
I hope I'm
struggle.
You never know. I'm a hopeful public health nurse.
Can a state impose a single payer healthcare system
After
in the
2017.
context
After
of
2017.
how?
Yeah, there's a state option effective 2017 where states, if they can figure out a way to do it for cheaper, can do an alternative payment system. And
Vermont's leading the way.
Well, they think it's unclear exactly what that will look like in Vermont, but it's a possibility.
Some people call it the People's Republic of Vermont.
That's right.
We'll see if they can do it, and maybe you'll get your wish that come October, when this all goes online, your friend Derek Jeter will be on television saying, hey folks,
And
we
Jay-Z.
just won our 28th World Championship. Now go buy your healthcare plan.
Oh, I like that way that sounds.
Thank you both very
Thank you very much.
Up next, breast cancer. A new study puts mastectomies in doubt. Every year, more than 200,000 American women are diagnosed with breast cancer. 40,000 die of the disease each year. A recent study from the Duke Cancer Center suggests that most women with early-stage breast cancer who undergo a more modest procedure that preserves the breast will live just as long or maybe even longer than those who undergo a total mastectomy. What are women to make of today's treatment options? Into the 1970s, the treatment of choice was still the far more radical and disfiguring Halsted surgery. If we follow the history of breast cancer treatment, how much do we see a trail of scientific advances? How much social and political forces affecting medical practice? Joining us, medical historian Dr. Baron Lerner, author of The Breast Cancer Wars and many other volumes, and Dr. Sylvia Formenti. She chairs the Department of Radiation Oncology at the NYU Langone Medical Center. Thank you both so much for coming in. And Dr. Lerner, tell us about some of this history. What was this Halsted surgery, for example?
Well, the Halsted operation was devised by William Halsted, a famous surgeon in the late 19th century, and what that operation entailed was a woman would lose her breast, the lymph nodes on the side of the cancer, and both chest wall muscles. So it was a dramatically large operation. The idea was if you did a big enough operation, you could potentially cure more women.
And that went back to the 1800s?
1880s, 1890s, and to show how important an operation was and how it took over all of breast cancer, it wasn't really questioned until the 1970s.
And so was it science or was it culture that caused people to question this radical surgery?
A little of both. It turned out that there wasn't a lot of good science that showed the radical mastectomy was the treatment of choice. It was basically because that's what surgeons had been trained to do. So beginning in the 1970s, you got some renegade surgeons who came in and said, where's the proof that radical mastectomies had to be done? And then where it really got political was women got involved. So women diagnosed with an early breast cancer, small breast cancer, began to ask, why do I have to have this dramatically large disfiguring operation if I have a small cancer? Aren't there choices available?
But Dr. Formenti, well, you could excuse any woman or any man for that matter for being very confused because there seemed to be a lot of press in recent decades about less invasive treatments being more effective and then about more safety in radical mastectomies. Even for small cancers, early stage cancers, and now there's this new study from Duke that's in the news. How do you put it all together?
Well, so first of all, the most important studies Baron was mentioning before were prospective randomized trials. And an important one actually from Italy with somebody I trained with.
A prospective randomized trial.
So,
stop and define the term for a minute.
So it's a very reliable way to establish evidence. So, you know, the process of medicine and learning in medicine is quite empirical, you know, particularly in breast cancer where you have to wait many years to get an answer.
So you start with a large group of women who have relatively the same degree of health. You follow them with different treatments or lack of treatment over many years.
Actually, it's more complicated than that because you don't make them choose the treatment, neither you choose the treatment, right? So you assign them randomly. So you have to have them consent to participate to this random assignment. And you know, there are particularly two very important studies, one in Europe, run by Veronese, and one in this country by Bernie Fisher, and where they, you know, they had the courage to randomly assign women to either mastectomy or less surgery with radiation, right? And they even tried less surgery without radiation. And at the end, and now the data is mature to 30 years of follow-up, which is the best way to establish evidence. You want to follow the same sample of women for a very long time.
And what they find?
They find that not only the the two approaches of mastectomy versus less mastectomy, so segmental mastectomy, less surgery, segmental mastectomy or lumpectomy with radiation are equal in terms of local control and survival. So it was as safe to keep the breast, much less disfiguring treatment, and with the addition of radiation, same survival.
And do you buy this study? Do you believe this finding? Is it good science?
That's outstanding science because it's the way to remove as many biases as we can. Otherwise, it's difficult to interpret data. And one of the challenges of the paper you're mentioning is that while I think it's very assuring, and maybe you want to talk about that paper a bit more. So that is a very interesting analysis of very large database. So what different approach, instead of following, randomly assigning women to different treatments and then following them for many, many years and see the outcome, you can look at a database that goes backwards, right? You can see women who were treated 30, 40, sometimes 50 years before, and then follow the records of their outcome on paper, right? And see whether 20 years later, how many are alive, did they develop recurrence, how much they utilize the healthcare system, did they have complications from treatment, and that's the approach. They did this kind of tumor registry study.
So what's the takeaway from this new study as far as you're concerned, having followed the history of this?
Well, this new study puts yet another twist in the history to the degree that you believe the science. But this study pushes even more the notion that lumpectomy is as good as mastectomy. This study argues that it might even be better. For some reason that doesn't seem to make a lot of sense, women who get smaller surgery seem to survive even better than women who have their breasts removed. Now, this is one study and there's some problems with it. The good thing about it is that it seems like the message that's been getting out there for decades, which is more or less that these two treatments, breast removal or lumpectomy and radiation, are more or less equivalent, are both effective treatments. This study corroborates that.
One thing to keep in mind, though, if anybody's being faced with this choice, is that there are individual differences, right? It depends on your genetic profile. It depends on some other factors. Even if you take into account the information in this new study, which would be the right kind of treatment for any given person?
Absolutely. One of the take-home lessons of breast cancer, and we're only beginning to learn the different ways in which different breast cancers have different tendencies, different genetic backgrounds. Each woman has to make an individual choice about what treatment she wants. The real trick is balancing the science with the politics and the opinions, because a woman, I think, undergoing the option of various breast cancer treatments is going to be bombarded with advice and information about what she should and shouldn't do.
So, Dr. Fermenti, this new study, it looked at the records of 112,000 women who had early stage breast cancer and followed them from 1990 to 2004, roughly. So that's a lot of subjects over a long period of time. But still you have questions about the reliability of
No,
this
no,
study,
I actually think the study, in a very reliable way, analyzed the data set they had access to and use all the variables, all the information they could utilize from the data set. The problem I'm having is that the conclusion of the study is, in fact, that the women who had lumpectomy and radiation, the analysis, as you pointed out, was really focused on two very specific subsets in the general database. Women who had lumpectomy and radiation versus women who had mastectomy without radiation. And they showed that the two subsets were at least equivalent, and probably in some subgroups, the women who had lumpectomy radiation did better in terms of survival.
And this seems impossible to you or illogical. There couldn't have been some ill effect of the surgery itself that wound up shortening their lives eventually?
I think it's more complicated than that, because in fact, in a very honest way, the study is looking at some of the potential biases or limitations in interpreting the data. For instance, we know that access to radiation units may convince women to undergo radiation or not. So if they are, for instance, women with lower socioeconomic status, may more likely to get mastectomy because they don't want to take time off treatment. Radiation still is many weeks of daily sessions at most sites in the country. So they corrected for socioeconomic status and was one of the variables they included in their analysis. They corrected for everything they could, and they also found that women with more comorbidities, so women who had other diseases in addition to breast cancer, whether they had heart disease, cerebrovascular conditions, chronic conditions in general, chronic respiratory conditions, diabetes, hypertension, they were more likely to undergo mastectomy. So more fragile women will get actually the bigger surgery. And that is well established.
And so did the surgery really cause them to have poor health, or was it these underlying
That's right,
conditions?
this underlying condition. And also one point I noticed was not reported in the study is that when you have those underlying conditions, you're also less likely to utilize another form of treatment, even for early breast cancer, which is either anti-hormonal treatment, a drug called tamoxifen that is used often for hormonal receptor positive tumors, or chemotherapy. In some of the women with positive lymph nodes, probably the women with comorbidities will have less chemotherapy. So both these treatments have an impact on survival.
Honestly, I was wondering about chemo in
right.
this study because it seemed to compare surgery and radiation, but the other very common treatment that people get for cancer is chemotherapy.
And I don't think maybe their database had all the information about chemo and hormonal therapy. Particularly, you never know for hormonal therapy, even if it's prescribed, whether women take it or not. So I think that is a missing part.
So, Dr. Lerner, do we learn anything from the history of breast cancer treatment and the politics and the sociology of it, that doctors are slow to adopt the latest scientific findings, that what they learned in medical school or as younger doctors gets kind of imprinted as the right way to do things, and they become more skeptical than they should be of new findings in terms of actually implementing them in their practices?
It depends. Certainly that was the history of breast cancer. I mean, the people who were insisting on the large operation, the radical mastectomy, that's what they had been taught for years and years, and they wouldn't change. And the surgeons in the 1970s were incredibly stubborn when the data began to change. Now it's, in a sense, even more complicated because women, you know, come to doctors' offices, they've read things on the internet, they have friends who've undergone a treatment, and sometimes the doctors, I think, feel obligated to just give a menu of options to patients. They sort of throw their hands up and say, well, you could do this or you could do that. So in some ways, you almost wish the doctors would be a little bit more proactive and say, you know what, let's look at your situation and maybe even recommend something.
Do you find this in your practice? I mean, we do have a great dilemma in this country between wanting to trust doctors because they have expertise and wanting as lay people to have the populist choice to determine what our own treatment is going to be from a menu.
So personally, I find the challenge in offering options to patients, not so much because of the difficulty. There is some complexity in explaining the options. I think women at the end really have to make the choices themselves, and it is our job to make it very possible to make the choice.
And make it very clear.
Very
and that means
clear,
having
very
very
simple.
good statistical information about your risks of this versus your risks
right.
of that.
So
right?
that is all feasible, and we try our best to do. And to a certain extent, medical school also teaches you how to present options and try to be as unbiased as possible. What I think is difficult to challenge are the biases patients come with.
That the patients come with.
Yes, so you can offer a lot of educated, and complex information. You can even make people understand the information, but nevertheless, the patients may feel relieved by giving up her breast. And that is an emotional and psychological choice that you can, in a very non-intrusive or trying not to be intrusive way, challenge a little bit, but at the end you have to accept the choice of the patient.
So do you talk to patients about exactly these things?
Absolutely, and one of the fascinating last chapters or next chapters in this whole story is that now in many cases women are coming in diagnosed with breast cancer or at high risk of breast cancer and asking for mastectomy. So in a sense, things have gone 180 degrees when you had women in the 1970s saying, I want to save my breasts, these doctors are taking off too many breasts. Now some women thoughtfully come in and say, you know what, I'm at high risk, I don't want to keep getting mammograms, this is making me too anxious. If I have breast cancer, I want the breast removed and maybe even the second breast that doesn't have cancer. So this just shows the ways in which breast cancer in particular, I think even more so than other diseases, becomes this very almost personal and political statement in addition to a scientific challenge.
Your specialty is radiation.
Yes.
How has radiation therapy changed since you've been in practice?
Oh, it's changed enormously because the attention has shifted toward, as I said before, we discussed before, radiation plays a big role in reaching this equivalence to mastectomy in terms of local control and survival. And the question is how to make it more user-friendly. So how to reduce the number of fractions. There are a lot of studies looking at that aspect. And instead of having 6 weeks of Monday through Friday daily visits to the radiation unit, we're trying to do it in a more compact way. And again, using the structure of prospective randomized trials, showing equivalence, that it is as safe to go faster. So fewer weeks of attendance to radiation unit. Or selecting a subset of patients where you don't need to treat the entire breast. You can treat just part of the breast, and then it can be done in much faster ways as well. And finally, maybe start studying whether some patients could do without radiation. Maybe elderly women that are very low risk may just get the lumpectomy surgery without radiation. But very careful investigations to try to reduce the morbidity and the difficulty of attending, the issues of adherence to treatment.
So looking forward, Dr. Lerner, where do you see the cultural and the political and the social sides of this going next?
I think, if you think about healthcare reform, one of the aspects of what we want to do is get the best science out there. So one of the ironies is that we've pushed for so many years patient preference. Patients should learn about their diseases and get to choose, but there's going to be a pushback now, I think, when you think about insurers paying for procedures, and if there's something that's scientifically better, that costs less, are we obligated to pay for the other procedure just because women want it? So I think there's going to be an interesting ongoing tension in breast cancer and other diseases between this dynamic.
Is that woven into Obamacare at all, as far as you can tell?
It's woven in, but no one's figured it out yet. And I think, but one of the ironies is you could say, for looking at breast cancer, that the first thing Obamacare should cut out is mammography for women in their 40s, because it's really not a very good test. But trust me, that's not getting cut out because, again, it's such an important test and a politically important test for women.
Do you agree with that?
I do. I really think one important ongoing change in this country is putting a lot of attention on evidence. So, there is a lot of emotions, a lot of perceptions, a lot of preconceptions, biases, and until you can prove that something is really worthwhile or working, I don't think the public should embrace it, and it is a duty to help them not embrace it.
Right, but even that is a balancing act, because how much proof do you need that something does work versus how much proof do you need that something doesn't work in order for a patient to take a chance on it if there aren't other good options? And so we go round and round. But I guess we'll all agree that evidence-based medicine is better than faith-based medicine.
Absolutely, absolutely, absolutely.
You just have to figure out what the evidence is.
Well,
and that's where it
how
gets
much
tricky.
evidence we
Right.
really need, that's right.
Yes.
Thank you both very,
Thank
very
you.
much.
You're welcome.
Up next, entering the era of open culture, where the contents of museums are accessible to all. It's been almost a month since the tragic passing of free culture activist Aaron Swartz. During Aaron's short, productive life, he was admired and condemned as he worked to unlock the vaults of human knowledge. Swartz uploaded the entire bibliographic data set of the Library of Congress to the open web. Previously, it had been behind a paywall. With his spirit in mind, today we ask what our museums and other cultural institutions are doing to open their doors digitally to share the art and history they've carefully guarded for centuries. Joining us, Cooper Hewitt, Digital Media Director Seb Chan, and connecting with us live via Skype from Portland, Oregon, longtime Wikipedia editor Pete Forsyth. Thank you both very much for joining us. Seb, tell us what Cooper Hewitt is doing.
Well, now we're actually closed. Our physical building's closed, so I've come over from Australia to help get Cooper Hewitt up on the web and to expose as much of its large collection as possible. And this I think is an important moment, because we're at a time when visitors to all sort of museums have the potential to see all of the works of other sort of museums whilst they are visiting the museum they are physically in. So it's an exciting time to be doing this work.
And do you see this as just an opportunity to put the museum's collection out there so more people can see it, or do you see it in a larger cultural, even political sense, as some kind of open access movement?
It's certainly about open access, although it's also really about connecting museums globally. I've spoken previously about creating a cultural seed bank, a global cultural seed bank, where all the museum treasures from around the world can be navigated, discovered, and explored.
Pete, where do you come to this discussion about open access museums and other cultural institutions?
Well, I've been a Wikipedia contributor, writer, editor for about 6-7 years, and that's always been driven by a passion for sharing information. One kind of project that I've been involved with in a number of ways, both as a volunteer and as a consultant, is with Wikipedians in residence. So the idea of a Wikipedian in residence is basically a person who spends time, often in a paid position, with an institution, whether it's a cultural institution, a nonprofit, even a university, to basically build bridges between that institution and the international, maybe volunteer community that identifies with the mission of that organization, so that they can work hand in hand.
Can you give us an example of where that was done effectively?
Well, one example that was recently reported is with the Walters Museum in Maryland, which they did two things that are closely related to each other. Number one, most of their holdings, they have a number of holdings that are in the public domain, older paintings. So they donated 18,000 images, digitized images, to upload to Wikimedia Commons. And then in parallel with that, they developed an internship program inspired by the Wikipedian in residence model, so that they could have someone who could help them think through the best ways to incorporate that content in Wikipedia. And the result of that is that there are thousands of Wikipedia articles in 40 different languages that make reference to the holdings of the Walters Museum, and that have that help to share that information around the world. And in less than a year, that content has been accessed 10 million times.
Wow, and I guess with our viewers seeing on their screens many miniature icons almost of what's at the Walters, I guess they can click on individual ones and see them more full screen. So I think this is an example of that right now. This is, if you can read it, folks, Abraham. Are you familiar with this piece of work, by the way?
I am not actually, but it looks as if it's a beautiful work that blows up to quite a large size.
Parable of the Wheat and the Terrace, and I'm not familiar with what it is or what era it's from, but there's an example of art online. So let me go ahead, Pete.
Well, I think what it's important to note that what we're looking at here, so the U.S. National Archives has also had a Wikipedian in residence for some time, and they've used the term citizen archivist for a kind of person that they want to connect with. And just as an example, through their engagement, someone uploaded an image from the 1930s, a photograph of an alley in D.C. that nobody would have known existed, but it was in their personal collection. So I think it's important to note with something like this, what we're looking at right now, this is not so much a public-facing interface. This is an interface that's designed to help individuals who are passionate or interested about these holdings think together about ways to express it to the public. Mm-hmm. So it is publicly viewable, but it's not really an end-user-oriented display. It's really, this is the work in progress. This is the collaboration tool.
So Seb, are you torn at all as a museum official between just wanting to make as much art and knowledge as possible available to the largest number of people by releasing it online, and protecting the museum's control of the images and other things that it owns?
There is a tension there, but it's overstated by many museums, I think. And I think really museums are looking more at their public mission now. We're one of the Smithsonian museums. We are a public museum. We have a responsibility to deliver to the public and have global impact. And I think this is where public museums particularly have a responsibility to see their works and their knowledge spread as broadly as possible, and engage citizens in as many ways as possible. It's really about relevance. It's about asserting a museum's relevance to its community and to the world at large. Exhibitions show a very small portion of any museum's collection, and yet we have now, with digitisation, such a great opportunity to spread many more things than we can.
And yet, Pete, the late Aaron Swartz was considered a pirate by many because he would do things like make the collection of the Library of Congress, another very public institution, more public online, breaching the paywall.
Well, I think it's when a term like pirate is a pretty loaded term. The thing about Aaron that I think is clear to anyone who worked with him, or I didn't work with him personally, but who encountered his work, is that he was very driven by a vision of an internet that was built around the free sharing of information, but not a total anarchy. The things that Aaron did were guided by a very strong beliefs about what should be available to the public if it was driven by public funds. So, I think with a term like pirate, we have an image of someone just completely based in self-interest, going and pillaging and ignoring property laws and principles of ownership. And that's really not what Aaron stood for.
Do you think, Pete, that his death recently will help foster the movement that he was a part of?
Well, it's very hard to say something like that. I think at 26 years old, it's hard to deny that his best work was surely in front of him. I think both as a person and as someone who had a tremendous amount to offer the world, it really is a huge tragedy to lose someone like that. But it certainly has been a sort of a galvanizing moment. And I would just say for myself, I've had a number of conversations that have kind of brought things back to the importance of the work that a number of different people and organizations are doing to make the internet work better for the world, and not just for individual private interests, but for advancing the cause of knowledge. And I think many of those discussions happened as a result, or happened as an outcome of that very tragic loss.
And I gather that you went to a number of memorial services for him. So beyond the obvious grief that would have been expressed there, did you also hear ideas or a certain kind of resolve?
Absolutely, and I think the resolve is really the key. Is when you get many people and many organizations doing diverse, great things. As in any area, there's a tendency sometimes to get caught up in our own work and not pay so much attention to the work that's going on around us. Even as we try to, we sometimes lose touch. And I think an event like this really serves to remind everyone at the same time that we are working together, that there is a very large international community that's very much bonded by the same principles. And really, the controversial aspects, those are the edge cases. I think the driving force is the idea that information should be widely available and easy for people to find and use, and are generally principles that anyone can get on board with. It's not a movement that's driven by trying to take property away from anyone.
Let's look at another image, or an image from the Google Art Project. Let's put this up. And are you familiar with the Google Art Project, Seb? This is just a 20th century painted fan that we
So this is actually
happen to see, but I think it raises the question of licensing.
This is in fact one of the fans from our Cooper Hewitt collection. Cooper Hewitt put in 1,500 works that we had rights for or were out of copyright. We gave them to Google, and we also gave kind of them to other providers too, as a way of connecting them to other works held by other sort of museums, and to create that. To put our content within that interface that is so critical for the end kind of users to explore. This is a reasonably good interface for navigating multiple museum collections in a way that perhaps Wikipedia has the raw assets, but it doesn't allow that easy navigability, although I know Wikipedia is working a lot on that.
So you're talking about looking at certain types or certain themes in art and actually moving from one museum's collection to another's, for example?
Yeah. Themes, places, artists, people, ideas. This sort of notion that works of art or a particular person's series of works are now spread amongst many different museums. The internet gives a good way to reunite those kind of works and reunite works by acquaintances of, friends of, made in the same studio as. These sorts of ways that you can reconstruct the past in a way that, in many ways, the splitting up of collections by museums and by dealers and others has, made difficult pre-internet.
It's a kind of inter-institution curation.
That's right.
That you're talking about.
Yeah.
But how does this affect the ability of museums such as Cooper Hewitt to survive financially? You can monetize by charging admission when people come to a museum, or even suggested donations, and most people give something. But something like this, maybe this is why the Library of Congress put up a paywall, so people would have to pay to use all these things that they weren't coming to see in person. And it costs money, of course, to do all this technological organization and display of the work. So is this, a threat to museums' financial viability?
Not at all. I mean, digitization and scholarship does have a real cost, and scholarship is never finished, and digitization can always be done at greater resolutions. We're talking about 3D digitization at the moment too. But I do think that because museums' biggest challenge is that people are just not aware of the great works they hold. So such a small proportion is on public view that really museums face greater opportunity from exposure to the public of their collections than any threat. That the public will be satisfied by digital reproductions. In fact, I think that in many ways, seeing works on kind of a line creates a demand to see them in kind of person. And in my work at the Powerhouse Museum in Sydney, we found that in fact releasing our collection to the web very early on greatly raised demand for private tours and queries about why isn't this work on show? I want to come and see it.
So people want to see
That's
the
a
real
huge,
thing.
I mean, actually the real
It
challenge
drives traffic to the museum rather than suppresses traffic.
which is in fact a challenge in many cases.
So whose Mona Lisa is it anyway? There is a partial answer. Thank you both very much for joining us for this fascinating discussion. And listeners, go look around online. You never know what art you're going to find these days. And that's our program for this week. We premiere a new show each Wednesday evening at 7:30. Next week, our Unpopular Congress, in fact, and on Netflix. And tune into my radio program weekday mornings at 10 on WNYC 93.9 FM and AM 820. Tomorrow, how fashion reflects culture in different countries. I'm Brian Lehrer. Thanks for watching.